Thanks so much for inviting me back. It's always a pleasure to come back to the RSM. I think these little lectures and seminars are great, and we get some good quality information, hopefully, out of the day. So I'm going to be talking about hip radiology investigations. I know you've had a chat from Dr. Johnson this morning, which is more about hip and groin. And so I'll be touching on a few sort of concepts of that as well, but we'll be much more hip focused with this presentation. So I'm a sports medicine consultant, and usually when we are thinking about investigation, we're trying to add to our clinical picture and our clinical reasoning. So a lot of the time we're weighing up actually what is the right investigation for this particular patient at this particular time. And that changes throughout the injury course, the history course. It changes to the age of the patient. It changes from the type of mechanism of injury you're suspecting. But the most important thing it changes is via your clinical examination. So you may clinically examine a patient, and your thought processes about what investigations needed next completely changes. So what we'll do is we'll talk through the key sort of imaging modalities with regards to hip pathology. We'll talk about the clinical applications, and we'll just finish off with a couple of case histories at the end and try and put it all together. So let's start off with X-ray. Oh, no, before that, just a little bit about me. I'm a sports medicine consultant. I work at London Bridge as the lead for sports medicine there. I'm employed by the British Tennis, where I work looking after the pathways there, men's, women's and juniors. As well as doing some lecturing at King's College London. So happy to chat through any of that stuff if anyone wants to. So I'm not sure whether Dr. Johnson talked about this consensus statement, but I'm sure most of you are familiar with it. When you are thinking about organising investigation for the hip and groin, you have to be quite specific about what you are asking for, and in particular what clinical area. And again, that comes down to your clinical assessment. It's making sure you're spot on, saying, actually, I feel confident this is a hip issue, and it's not adductor, it's not inguinal, it's not hip flexor, or it's not pubic symphysis, for example. So a lot of that will change after your clinical assessment. And the reason is, you need to be quite specific about what you request. Because if you're sending a patient off to a radiology colleague, they will only be working off the information you give them. So if you ask for you think something might be inguinal, but you just put a generic MRI hip, you won't get the proper images, for example. So it's really, really important to be really, really specific in your questioning and your request form for any further investigation. I think with SCM consultants, it's slightly different, because we obviously see our patients and then assess them. So we often are very, very, almost sometimes too specific about what we're requesting, but having the relationship with the radiologist so you can discuss scans and go through different intonations of what scans are the best is really, really important. So, interestingly, in this Doha consensus statement, they've missed out the hip. So they've thought hip is actually a separate entity. It's not really related to groin pain or inguinal pain. So we're putting all of this aside in terms of the Doha consensus statement areas, and we're going to be focusing on hip for the time being. Right, so let's start with X-ray. When would you do an X-ray? X-rays are great because they show you things you perhaps wouldn't be able to see on other more detailed investigation like MRI. So the first instance is alignment. So if you're looking at wanting to know what the general biomechanical alignment is for someone, what their angles are doing with the hips or at the knees, great place to start. You can order a hip X-ray or a long leg view X-ray, and then you can get all sorts of information about that, which we'll touch on. Acute trauma, so if someone's had a fall and a difficulty walking in the A&E setting, for example, or in the minor injury type care setting, X-ray is going to be your first investigation. Very easy to do. Can rule out lots of different pathologies. Again, but you've got to be specific about your questioning. You've got to say query right hip injury, right hip fracture, and not just pelvis, because then otherwise you won't get the right views and the right alignments from that point of view. When you're talking about patients with arthritic changes, I think, again, X-ray is very, very useful. If you're suspecting someone's got very severe OA change, not just because of their age, but again, many on examination have got lots of range deficits. They can't really go into internal or external rotation, very painful, very tight. You're thinking, oh, this is more arthritic. It's just far better to get an X-ray to look at the bone surfaces first and the hip joint, rather than putting the patient through an MRI scan, which is timely and may have cost implications as well. So know your patient from that point of view. I think from a red flag point of view, if a red flag scenario has crossed your mind and time is of the essence, you cannot go wrong with an X-ray. You will see bony pathology, you'll see significant soft tissue pathology as well. So really worth considering from that point of view. X-ray, very cheap, very quick, very accessible. I don't know how many of us work in the primary care setting, but really, really useful to access in that sort of setting as well. Normally can get things done the same day. Getting the report back can be challenging, but often, at least they'll have the investigation done. Like we said, unable to visualize soft tissue or cartilage in the X-ray, but then that may not be necessary. Just think about the radiation dose, particularly in your younger patients. Very delicate area, very sensitive area, particularly in sort of anyone for the ages of their teens and 20s. That's men and women. So just be careful about who you're requesting X-rays for and make sure there's a good clinical indication to do so. So, alignment. Oh, before alignment, sorry, anatomy. So with an X-ray, you can really be detailed about all the anatomical sites and variations of the pelvic area and the hip joint itself. Anyone point out which one's the male and which one's the female pelvis? Someone's going to put their hand up. Female on the left. Yes. Why is that? Exactly. So greater space between the ischium. Look at the obturator foramen, different size and shape. Pelvic inlets wider. Lots of different reasons. So very, very useful to be able to ascertain that right from the beginning. And pathologies do differ in hip and groin in men and women. So I'm a big fan of alignment views. Our orthopaedic colleagues use them a fair amount. I think in sports med we're starting to use them a bit more. But I think they tell you a lot, because you can firstly determine if you get a good long leg view standing sequence, you can tell things like anatomical leg length discrepancy. You'll be able to look at things like the offset, which is basically the distance between the femoral head and the shafts, and that gives you some good calculations, and we'll see how that's relevant in a second. We can always estimate Q angles clinically, so when you're looking at alignment of the hips and how much angular variation there is at the hip joint. Q angle is very useful, but if you want to do that properly or radiologically, you can use the neck shaft angle. So neck shaft angle is essentially a very descriptive way of looking at the angle between the neck and the shaft, and to give you an idea of what's happening and how that may interplay at the hip joint, but also at the knee joint. So very, very useful to get long leg views. I think if someone is coming in with, they've got massive genu valgus or genu verum, often you're thinking, oh, is that coming from the knee or from the hip? I think this is a way of just determining that and being really clear on it. For example, you might have a patient who's got severe genu valgus, and they've got quite severe OA medial compartment of the knee, so that's just taking the tibia outwards. Or it might be coming from the hip joint. They might have quite a steep angle at the neck shaft angle. So I think that's really sort of good screening investigation to have. I often order if I think there's, for example, a significant leg length discrepancy, and they've got a compensatory lumbo-pelvic scoliosis or lumbothoracic scoliosis, I will sometimes organise a scoliosis view X-rays to accompany this as well. But again, keeping in mind how that's going to change your management and whether you think it's required as well. Offset and coverage. So we talked about offset briefly, and why that's important is because it gives you an idea of force production across the hips through different anatomical muscle groups. So your main one being your abductor versus your joint reaction force versus your adductor force. And there's two examples of why hip offset can be disrupted. So in the middle picture there, top right, you've got, I'm just going to get my mouse up. Here we go. Here's a pointer, there we go. So you can see here, there's some OA right hip, and what that's done is actually effectively lengthened the femoral neck. So that's increased the offset. And what might that do? That might overload your abductors, and might overload the general gluteal muscle bulk, so you might have accompanying greater trochanteric bursitis or increased load of the general glutes. An opposite is a shortened hip, right? So this one's got perthes. You can see the neck is shorter, and therefore your lever arm for the abductors and adductors and all the rest of the hip and groin muscles is shortened. So that doesn't produce the most biomechanically advantageous hip from that point of view. So you might lose function and strength from that point of view. So two ends of the spectrum there. We often look at coverage as well. So particularly for your younger, fitter patients in their 20s and 30s and even 40s, sometimes you're querying, okay, is this a sign of hip dysplasia, or do they have an over coverage, or is there some element of hip impingement? I think an X-ray is not the definitive way of looking at that, but it's a very useful way of looking at that. So we call this the crossover sign. So here you can see the red line marks out the anterior aspect of the acetabular rim, and the blue line is the posterior. And what happens if the anterior one crosses over the posterior, you get this figure of 8 sign, which basically means there's a bit of anterior over coverage. There's other ways to do that using angle. The center edge angle is probably the one we use the most on an X-ray, and it's just saying what is the angle between the vertical line and the edge of the acetabulum, basically, to see how much over coverage there is. And if you've got someone with a really over coverage, so we're talking anywhere between 40, 50 degrees, you can imagine they're going to be impinging, you can imagine they're going to be suffering with lots of flexion-based issues, where someone who's got a dysplastic hip may be hypermobile, may have a thickened labrum from that point of view as well. So that kind of is very, very useful when you're trying to get an idea of the biomechanical picture. X-ray is also useful, like we talked about, in the acute setting for fractures. So we're all, from our A&E days, I don't know if anyone's still in A&E, but we're all a bit worried about intracapsular stuff. We think, okay, intracapsular fractures generally aren't healing as well, so we want to make sure they are looked after a bit better. Where, on the other hand, some greater trochanteric fractures can be managed in the outpatient setting and in the community. And that's just not more elderly patients, that's young people as well. So X-ray is very, really useful from that. So, for example, here you can see the intertrochanteric fracture line. That's the kind of usual patient you'll see with a shortened hip, externally rotated in A&E. These you sometimes see in the athletic population, either from there's been a significant avulsion of one of the gluteal tendons, or you can often see it on the lesser trochanter as well from psoas. So either a tendinopathic picture or a slight avulsion in adolescent as well. So, so X-ray can tell you that stuff if you're willing to look closely. I'm sure we're all familiar with this. This is a Sufi appearance, frog leg view, which we can do either that's happened acutely or that's happened over a period of time, and you've got a young a child who's come in with groin pain and it's been persistent over a period of time. They're not always dramatic. Sometimes they can present more subacute or chronically. So just keep an eye out for them from that point of view. And again, X-ray very, very useful. So for those of you who look after the adolescent and athletic population, this is a bit of a minefield when it comes to hip and groin areas. So lots of different sites that can be injured, from a traction injury, an apophyseal type growth plate injury. So either at the top, or the ASIS, AIS, less trochanter, as we discussed, the ischium. And just X-rays can be really useful in the acute setting as well from that point of view. Again, my personal practice is not so much acute stuff anymore, so I would always want to try and do either an ultrasound or an MRI for a young athlete in this scenario, and just minimise the radiation risk. But if you're working in a minor injury unit, that might not be accessible, so an X-ray, a one-off X-ray may be more suitable in that environment. Just going through them, where would you more likely see an iliac crest avulsion? What sort of exerciser? What was that, sorry? Gymnast, yeah, exactly. So anyone who does a lot of trunk rotation, lots of oblique contraction. Interestingly, the ITB inserts up there as well. So sometimes you see a lot of ITB, really severe ITB friction syndromes that are not just distal, but also proximal as well. So making sure you've considered that. AIS avulsion, anyone? Footballers, yeah. Anyone doing max kicking? Pubic symphysis disruption. Pregnancy. Equestrians, falling off things. Motocross. Usual examples, we are straddling something. And hypermobility. So I'll be much more looking at this sort of area in patients with hypermobility or any other form of connective tissue disorder. But pregnancy is obviously the main one as well. And you can characterise that with measurements as well, to how much dysfunction there is, and there's different grading systems from that point of view. Right, moving on. MRI. So, if you feel there's more of a soft tissue component, or you're thinking, you know what, I'm not overly happy with the bone here, and I'm thinking there may be a bit of a bone stress phenomena, not necessarily a fracture, but more there is an overload type picture going on here, or you're thinking there's cartilage labral pathology. MRI is going to be your a firmer investigation for you in kind of what you're going to need to be seeing to refute or go along with your clinical reasoning. There's no radiation. It's becoming way more accessible now, so I imagine most of us will have access to MRI in some form. It's multi-dimensional, so lots of different viewing angles, as opposed to X-ray, which you can obviously have to ask for different views, but MRI tends to give you a bit more clarity from that point of view. It can still cost a little amount, particularly for NHS budgets or self-funding patients, or patients who are trying to pay for their own investigation, for example. It's usually found in more secondary and tertiary centres, again, so primary care practitioners may not be as exposed to accessing MRI. So just some flashbacks from this afternoon's talk, this morning's talk, sorry, on groin pathology. This is some of the things where, if I'm just not sure what is causing it, I think, I'm not overly convinced it's the hip joint, I might ask for some other views. So I might ask for an MRI to say, please could you MRI the left hip, but also look at the right inguinal area. If you're going to look at inguinal pathology, so this is, you can see is an inguinal hernia here, so that's fat coming out from the inguinal canal. You have to let them know that, because they can do dynamic images where they do the Valsalva maneuver with the patient in the scanner and get them to sort of push out, and you get quite nice dynamic images on the MRI of the posterior inguinal wall defect, or whether it's a direct or indirect hernia from that point of view. I think just from a general overload point of view, so if you've got a young athlete and you think, okay, yeah, or not even a young athlete, anyone really who's not got their load management right, and you think there'd be some element of overtraining or not recovering properly, asking for a small view of the pubis is really, really helpful. So you have to ask for that. You have to say, can you do a pubic bone small view, or an adductor origin small view, and because otherwise you may not see these things in as much detail. It's very different getting a small view of the pubic area as opposed to a large pelvic view. So be very specific on your request forms. This is obviously an adductor injury where you can see the adductor avulsion, which I'm sure you're experts on now. And generally here some osteitis pubis and some pubic bone inflammation and some disc degenerative change. Often when in the MRI scanner, you can kill two birds with one stone as well. So you can ask for an MRI of the pubic and the groin and even the femoral shaft if you want to. So don't be afraid to get all your requests in. The only time that becomes an issue is, again, if they're self-funding a patient and they count that as 3 separate body parts, so the patient gets charged a few times. And I think sometimes that's difficult in NHS land where you've got different, you're allowed certain types of body parts. So just check that your provider's happy to do it. Femoral neck stress fractures. So here's an X-ray. So you can, if you looked, very, very closely, and you had the right clinical details on the request form, and someone was saying, "Oh, I thought there is a femoral neck stress fracture," you would probably pick that up if you're a relatively experienced radiologist. However, on an MRI, you get that real nice contrast with the fracture line against the pubic bone stress. So there's no mistaking there's a fracture line there. That isn't always the case, and this is obviously a fat saturated view, which makes edema look white. But sometimes the fracture line is a bit less evident because the bone stress has settled, or there wasn't that much bone stress, or you've got in there before there's significant bone stress. So most of the time, femoral neck stress fractures are picked up really easily on MRI, mainly because of that contrast with the bone stress that occurs. Other soft tissue pathology, not just the hip joint. This is something we really, really commonly see. So this is a axial view looking at the left hip, and this is the psoas tendon. So if you compare it to the right, it sits nicely on, nice black blob there. But here, lots of fluid, lots of inflammation, white and bright. So you could argue this is more of a hip flexor phenomena, hip flexor injury, or a psoas bursitis. This particular case was an acute injury. So someone was running, they felt a pop in the groin, and was able to run thereafter. And this is an acute hip flexor tear, for example. I think when you are diagnosing hip flexor phenomena, I think you always need to be a bit careful about whether it's a joint-related phenomena that's transitioning on to the hip flexors. But in this case, actually, it was a primary hip flexor trauma. So, ischiofemoral impingement, that's a diagnosis that's probably more helpful for the radiologist than it is for us as clinicians, but it can be painful. So you can have patients, again, to do with the pelvic anatomy of who have a narrowed ischiofemoral space, and quadratus femoris gets pinched, gets swollen, gets inflamed, presents similarly to a ischial bursitis. So this is the ischium here, and this is the space in between the ischium and the femur. So if it was a true ischial bursitis, you'd be seeing lots of fluid around here and edema within hamstring origin, but this is in between. So all your short external rotators, quadratus femoris, the gemelli, all that kind of stuff are going to be inflamed from that point of view. So you've got to just think about actually why is that? Is it a functional thing? Is it a biomechanical thing? What can we do to try and improve that? This one we're all probably familiar with. The gluteus medius tendon inserts onto the gradus trochanter, looks very inflamed, and this is an axial view as well, so you can see the black tendons surrounded by an inflamed bursa. So common pathologies. I think you see this much better on MRI than you do on ultrasound. Again, because of the contrast, and you often can't see how much fluid is within the glute med bursa on an ultrasound, where on MRI it's much more evident. So, CT. 5 minutes. So CT, I think, very useful when you're looking at alignment, acute trauma, when you want to try to assess bone healing. So that's a very useful function of CT. It's very fast. You can do like a trauma series in A&E. You can get 3D reconstructors as well. The main disadvantage is it's a high dose radiation, or you do get low dose CT scans out available now. Again, it's really only accessible in secondary or tertiary centres. So again, a further detail of when we're looking at over coverage or under coverage, we talk about acetabular version. So this is looking at whether you've got an under coverage or a dysplastic hip or an over coverage. So this gives you that extra layer of detail because you get the axial view, right? So you get the cross-sectional view. You can look up. You can say, okay, what are the acetabular angles doing? What's the femoral neck angle doing? What's the femoral shaft angle doing? And if you go far down enough, you can say, okay, what's the tibial angle doing? So if you're someone who's very pernickety about the acetabular versions or the versions of the lower limb, you're going to need a CT scan. And again, that's more useful for the orthopedic guys when they're doing their preoperative planning, but actually for SCM doctors, I think it's quite useful for giving you a fuller sort of biomechanical picture. Fracture lines, again, so sometimes we talked about MRI not being overly clear this is an MRI, for femur fracture lines. Here you can see a healing fracture line. So if you pick this up and the patient was 8 weeks, 10 weeks post injury, you could say actually it's the right time for a CT. So with a CT you can really diagnose whether the fracture is healing, as to whether there's sclerosis around the fracture site, and you can give a clear indication of where the fracture site is. So different sides of the femoral neck can give you different outcomes. So we worry more about these tensile fractures where the trabecular lines are not as compressed as opposed to this side. So these sides generally heal a bit better. If we saw a fracture line here, we'd be more inclined to be a bit more aggressive with the treatment, the immobilization, and even sometimes surgical intervention for those. As we mentioned, 3D planning. Very useful for, again, our orthopedic colleagues, but I think sometimes they can give you nice 3D conceptions around particularly acetabular overcoverage or Perthes, for example, about how it's affecting angles and things. So very useful. So we'll just finish on ultrasound. Ultrasound is, as you've probably seen for most of our talks here, it is our bedrock as an SEM doctor. And it's because it's an in-clinic test. You can do a lot of dynamic testing. It's quick, it's cheap. You need the expertise, you need the skills to be able to do and be clear about what you're trying to achieve with the ultrasound. Hip and groin is perhaps a bit more detailed area and requires some practice from that point of view. I've just got a couple of videos just to show you. Hopefully that's playing. Are we playing now? So this is a hip joint. You can see the femoral head, the femoral neck. This is the capsule as well. Oh, now it's playing, sorry. So this is something we do routinely in ultrasound clinic or LIS or SEM clinic, is a hip joint injection. So you see the needle quite very clearly advancing into intracapsular and the injectate going around the femoral neck. We used to do hip investigations and treatments under X-ray or fluoro. Don't need to anymore. Hip ultrasound, very, very good, very, very clear. And the benefit of bedside testing as well. So I would often do some impingement testing, inject, give a few minutes, retest, confirm, or repeat your diagnosis from that point of view. This is a nice video of psoas. So this tendon is psoas, and it's in an axial view. So you can see psoas jumping around here. So this is, someone classically says, so you see it snapping there. So someone's classically coming in with internal snapping of the hip and they're not quite sure what it is. You can often get them in the right positions, put the probe on psoas and reassure them your hip is not dislocating, it's just psoas that's going around. And often you have to see a good psoas bursitis or inflammation around that, and that will go some way to help diagnosing what's happening. So again, this is the greater trochanter, different facets of the greater trochanter. It looks very similar to a shoulder would look when you're doing an injection into the subacromial bursa, but this time it's into the trochanteric bursa. So your injector goes straight into the bursa. I'm quite generous with my fluid, so I will give a good amount of fluid to try and distend the bursa, and then again post injection testing. Right, I realise I've run out of time, but I was going to finish with a couple of case studies. So 14-year-old boy playing football, felt pop in hip and groin area on striking the ball, had some bruising around the front of the groin. He came into your clinic 2 days later. Before that MRI came up, what investigation would you choose? There's no wrong or right answer here, by the way. Hands up for ultrasound. Yeah, obviously proficient in doing it. MRI. Yeah. X-ray. That's fair enough, and that might be an access thing, 14-year-old, I would always try and get unless you think this is like really life-threatening or really limb-threatening, I'll try and avoid an X-ray if I can. Ultrasound's great. You can see this is the AIS. You can see the fragments pulled off, and this is the rectus femoris attachment. MRI, again, you can get extra bits of knowledge from just bone edema, so you can see the avulsed fragment, you can measure it, but then you can measure it on either of these modalities. What have they done wrong with this one? Why do a pelvic X-ray of the whole thing? Why not just do a right hip joint X-ray? You've exposed him to unnecessary radiation. You could have been really focused from that point of view. Just consider that. Second case. 76-year-old woman, pain in right hip, disturbed sleep at night time, needs a stick to walk now. Have you taken anti-inflams? Any thoughts? X-ray? Ultrasound? X-ray? You're suspecting OA hip, X-rays. This is a tricky one because if it's a trochanteric bursitis, acute flare, you're not going to show on an X-ray. So now you're umming and ahhing between the two of this is an OA or is this a trochanteric bursitis. The reality is it's probably going to be a bit of both. So we talked about what happens with the offset with an OA hip and the movement mechanics. They're undoubtedly going to get a bit of glute med flare and glute med tendinopathy. So you're much better off picking up the true pathology with an X-ray, and it's a screening tool as well, right? To look out for any other sinister pathology. So I think X-ray would probably be my go-to in this lady. Last case. 26, pinching on the left hip on sitting and crouching, unable to squat during workouts. Being very upset by that, can't do her Barry's boot camp. Gradually becoming worse. What would you do? Hands up for ultrasound. What are you expected to see on the ultrasound? Psoas? Do you think this is a primary psoas thing? Probably not. Secondary, certainly. After you've had some of hip injury, there's always psoas tightness, snapping hip, but probably not a primary psoas issue. Labrum? Maybe. Yeah. So I think, correct me if I'm wrong, anyone, but I think MRAs are a bit outdated now. I think if you've got a good 3T with good views and you ask for specific views of the labrum, lots of different protocols out there, but axial oblique views are generally quite good for the labrum. You can get enough information about the labrum to help your decision. I think there's no point putting someone through an injectate. I think if you're, maybe if you're doing a preoperative planning of doing some labral repair, you might want it, but for me, I would never organise an MR arthrogram of the hip. This is interesting. What's this? It's a cyst. Yeah, it's a labral cyst. So it's sometimes difficult to tell whether it's a labral cyst or a psoas bursitis, but you can tell this is septated. It's got little different bits to it, and this is definitely coming from the labrum. So sometimes the labrum doesn't look too bad, but they've got a big chunky cyst, and that's causing a bit of a compressive element. And if they didn't have impingement, they're probably going to have a bit of impingement now, because there's a big 2 centimetre cyst sitting there. So that's something that, again, you want to diagnose, you want to drain, or at least attempt to drain, and try and calm down from that point of view, and with the proper rehab. You can see those on ultrasound if you're, with the eagle-eyed viewers, but I think an MRI is definitely going to be the first choice investigation.